My name is Myrto Trakatelli. I am working at the University of Thessaloniki, Greece, and I'm an assistant professor of dermatology and venereology. I think people are getting to know more about skin cancer, especially in countries that before had no contact with the concept of skin cancer. I think that uromelanoma has changed a lot of things because it's now in countries that they had no primary prevention or secondary prevention actions before in the past. I think that we still have to find ways to communicate to people the points, the delicate points and the different aspects of skin cancer, because not all skin cancers are the same. So some messages I think have gotten across to the general public, such as black lesions are dangerous, but I think that other types of skin cancer are less well known, and so I think that there are other kind of messages we have to try and get across. I think we have to find a way to communicate to people the facts the way they can understand and digest them. This is the first point, and I think that sometimes we use medical jargon that for the general public is something that it's completely incomprehensible. So I think we have to make it easy for them to take the information and perhaps use more images to explain what we want to say to them. Well, I think that Europe is a very diverse area, and I think you should go to country by country example. I think in some countries the role of GP is extremely important, such as the UK, because the patients have no access to the dermatologist before seeing a GP. So it's really important to train the GPs to recognize skin cancer, and so that they can push forward the cases that are important, and also to inform the patients about it. In other countries, maybe it's at the present less important. We cannot say that it's not important at all, because it's a basic knowledge and it's important to train them, but less urgent than the countries where the people have no access directly to the dermatologist. I think it's kind of the ostrich syndrome, that they like to put their head in the sand. And it's a sad story, because many times I hear from a patient that they had been noticing the lesion for many years and that they were having concerns about the lesion, but they did not dare to go to the dermatologist. And sometimes I think it's also a matter of misconception. You know, I think in Greece and maybe in other southern or eastern countries, there is a wrong concept that if you excise a lesion, then it becomes cancer. Most probably attributed to old stories of people excising lesions and not sending them for histology. And so actually the lesions were originally melanomas and they gave metastases. But the people who did not know that they had melanomas thought that the actual excision caused the cancer. So sometimes they are, in a way, inhibited to go to the doctor, thinking that, oh, he's going to cut it out and then I will have a cancer. So this is one part of the problem, like a misconception. And the other thing is, I think everybody wants to think the best and maybe is afraid to face the worst. Well, you say skin cancer, but I would like here to separate melanoma from the other types of skin cancer. So the other types of basal cell carcinoma, squamous cell carcinoma are not that fatal. Basal cell is rarely fatal. And it almost rarely gives metastases, and squamous cell sometimes gives metastases, but this is not a very common event. I think melanoma, and especially thick melanoma, is a problem, and so for this kind of people, well, you have to give them the prognosis and explain to them that they are facing a serious disease. I think in this case it's a doomed scenario. We always try to give them, I think it's important to give to the patient the information in an informed way and in a nice way, and never give them everything black, because this is very, very bad for the psychology. I think the psychology of the patients is very important. Then the family is another thing. I think there is a cancerophobia, so only the word cancer is going to bring the worst reaction out of a family, sometimes even spreading panic to the patient, who would be perhaps in a better psychological state without the family's reaction. So the family could either make or break a deal, as we say, because they could either make the psychology of the patient better, or they could even cause extreme panic. I have seen families coming to get examined from head to toe, and sometimes they didn't have any lesions. So one mole or even nothing, and saying, "Oh, examine me, please." And I said, "But you examine yourself. You have not cause of concern." "Yes, but maybe I have something on me that I don't know." So it could cause considerable panic. We should do it. This is very important. This is, I think you're putting your finger onto a very important issue. I think one of the most important points of prevention is to teach the people, the patients first, because they might have a second skin cancer, but also everybody that comes in a consultation at a dermatologist's office, how to examine their skin for suspicious lesions. What are the key points? Because the patient himself can look at his skin every day, 24 hours a day, every day. And if he cannot do it himself, he could ask his wife or his family, or, well, you can always use a mirror. Even in the most uncomfortable areas, you could use a mirror. It's important to tell him, examine yourself from toes to the top of your head and look at it, because you know yourself better than I will know yourself. If I see you now and if I see you in 3 months, I might forget. Whereas you will see yourself every day, and you will know every new thing that appears or everything that is changing. So I think this is very, very important. It's a hallmark, I think, of prevention, of secondary prevention.